from Arvind Eye Hospital, Tirunelveli. He is getting the department. And thank you, Mohideen, for accepting a very late invitation to you. So over to you, Mohideen.
Yeah, and the topic about organ-less and suture lysis, I thought we'll take it a little deeper. So we'll see early intervention following glaucoma filtering surgery. So a filter failed in 3 locations, either block at the internal ostium, or you make a tight scleral flap, or some subconjugal scarring. So I'll be talking only about tight flap closure. So risk of failure in glaucoma filtering surgery if you use of AGM for longer duration, if you're not stopping before the surgery, at least a week, 10 days before surgery, if you're not practicing any use of preoperative topical steroids, the high risk of failure. Younger age group, previously unsuccessful surgery, a black rays, aphakia, pseudophakia, and near glaucoma is a high risk for glaucoma filtering surgery failure. So management depend upon the cause. Do a digital massage, then you do an organ-less suture lysis, or if you're putting a releasable suture, release a releasable suture, and for a few minor injections and needling and blood revisions, repeat surgery and tube procedures. The laser suture lysis, why? Relatively effective. It will avoid early blood failure. The extra measure to control over the operation. So what the selectively raise the subconjugal sutures as allows the postoperative tightness of intraocular pressure by increasing aqueous outflow. So ideally to be done 7 to 14 days following a glaucoma filtering surgery. And if you're using mitomycin C, you can delay for more than 14 days. So what lens to use? Hoskin lens, no financial interest. The laser you can use argon green blue, or you can use a double frequency Nd:YAG laser. The lens can be used Hoskin lens, easy to use. Hoskin has a blanches where you can blanch the congenital vessels, easy to visible the sutures. You can focus the suture, you can fix the globe. You can also use Zeiss 4-meter lenses, exactly the center point of it. You can use it for using a suture lysis. Other lenses can be a rich nylon sutures, or Blumenthal lenses also can be used over the blood for lysing a suture. So this is a video, just show you. The 2 weeks post-op with mitomycin C, we just cut one suture and the side suture. Apical sutures and the side sutures are intact. So once you do a suture lysis, look for spontaneous blood formation. If the blood is not forming spontaneously, then try to give a digital massage next to the blood. The first depend upon your experience, how much to give, and all depend upon your also pre-op assessment. So give a massage on the sides, on both sides, to elevate the blood. So you can see slowly the blood is elevating on the limbal side. So once you are happy with your blood elevation, then you can stop your suture lysis, and then you just give the patient steroids and just follow him up for next week and decide about you want to cut next suture or not. So the nice blood, as the patient look down, and also do a blood massage in a sit lamp, because you'll be doing a suture lysis and laser machine. And look for any AC complications, look for AC normal depth, any hyphema. All that you just look, and also you can look at the IOP. So bring the patient back to the sit lamp, do a massage, look the AC and look the IOP, then send the patient. So the power setting is you can use around 300 to 800 milliwatts. Make it a small spot size, 50 micron spot is very good because duration is 0.02 seconds. And technically don't cut more than one suture at a time, because we tend to do, sometimes we tend to do more cut. If you do cut more than one suture at a time, you will land up in a complication. So what are the complications? If you have subconjugal hemorrhage, if you have fluorescent stained conjunctiva, it will absorb more laser energy. So try to use less laser energy, because it can cause a congenital perforation. It's safe to remove only one suture at a time. So what are the complications? Immediate post-op complication, wound dehiscence. Excessive manipulation of underlying conjunctiva to locate the suture can result in a conjunctival wound dehiscence, sometimes requires a surgical repair. Congenital perforation, I told you, when somebody has a subconjugal hemorrhage, reduce your energy, somebody can have a hole formation. It heals in 24 hours time. A blood leak should be rolled out before performing an ocular massage. The other complication, hypotony, reportedly the most common complication. The incidence from 18 to 35%. So that's the reason you avoid vigorous massage and the laser machine itself. So bring the patient to the sit lamp, you see what happened to the blood, then give a massage. So good patient education and usually resolves spontaneously. And flat chamber, they usually will respond to cycloplegic and also aqueous suppression and patching therapy, especially for angle to the glaucoma. We always take atropine with us whenever we do suture lasers for angular glaucoma. After suture lasers, we put one drop of steroids and also put atropine immediately following suture lasers, especially for angular glaucoma. And also can conservative management with or without aqueous suppression, especially for external aqueous leak. Iris incision is possible. I had one case, still remember. A sudden decompression in the presence of small peripheral iridectomy can lead to iris incarceration into the ostium, requiring a surgical repair. Then you take it immediately because you try to give too much of pressure, sometimes it happens. Hyphema, it happens, it results in 72 hours. Meningoglaucoma, still possible due to sudden decompression following successful lysis. Onset is in 48 hours of the procedures. A risk factor persisting narrow angle with procedure high intraocular pressure. So anybody have very high intraocular pressure and narrow angle, you try to do a suture laser a little later. If you also use, don't stop atropine following, especially for angular glaucoma patients. So we have some European glaucoma guidelines. They say, consider focal pressure in case of poor filtration shortly after tuberculotomy, especially in your first week to 2 weeks, is a good measurement before doing a suture lysis. And how do you do it? Just give a massage next to your bleb on the sides, or to your side. Look for the bleb formation. How much bleb is forming? How much time is taking? So you know which suture to lyse. Some people put some suture, tight suture on one particular suture. So you can lyse that particular suture to get your bleb back. So it's done by a surgeon to assess your filtration, and better to do before suture lysis. If you feel some bleb is forming immediately with the slightest massage, don't do suture lysis. So look for the bleb. And then also can early postoperative intraocular pressure predict the success of mitomycin C tuberculotomy in angular glaucoma. So this study says, so if the IUP on the day 1 is less than 10.5, or IUP on the day 7 is less than 13.5, the relative risk of failure was 4.2. So cutoff value of more than 13.5 on the day 7, which achieves accuracy of 80%, the predicted success of IUP less than 15 without medication, and 50% for the predicted failure of more than 15 with the medication after surgery, respectively. So what the study says, a control of early IUP less than 13.5 millimeter mercury or less provide a better outcome. So immediate intervention after surgery has considerable role in maintaining filtering and change the probability of success following tuberculotomy. So take-home point is check IUP in day 1 possible, keep the IUP less than 10, and day 7 keep it less than 13.5, achieving a good filtration in the early postoperative period of tuberculotomy, associated with the procedure of the long-term success. Thank you. So we don't want a bleb to be, we want something to be turned, diffuse, and posterior filtering bleb, which is a lower one. Thank you. Yeah, I think I'll have. The next presentation is about iridoplasty. I think just finished off.
How many of you do the suture lysis in every given patient of yours? Any of you are doing trabeculectomy here? Of course, there are few people here. So most of the time, it is very less likely we are doing it. But the common question, Mohideen, is the common question asked is, we don't have an organ, can we do it with a YAG? So people mistake that the double frequency YAG as our regular YAG. So what is your advice? Have you ever tried doing a YAG laser?
I think you'll damage your lens. You cannot use a lens more than once. I think that's more. I think you'll damage your lens. The lens will get a crack if you use a double frequency. I never tried, but normally they say don't use it and crack your lens. Whatever lens, contact lenses it uses for doing suture lasers can get cracked.
Yeah.
I think definitely it is not advisable to use the cutting laser for doing the suture laser. You must use a coagulating laser like argon or blue-green or the frequency double. Yeah. Like he says, I have also had the bad experience of cracking and pitting a lens. When you do to the, don't do it. It's not worth the cost of a laser and the lens.
No, because it's a very commonly asked question, can I use a YAG laser to cut the suture? It's a very commonly asked. So one is the lens damage, and what we need to understand is we need to use a laser which is a coagulating laser, not the photodisruptor. We have to use a photocoagulator when you are doing it. But if you can really cut without any lens damage, it is up to you, but it is